Good evening, everyone, and welcome to week 5 in our PRI Breathing in COVID Times webinar. We are excited to have you here with us again tonight. Tonight's topic is managing chronic obstructive lung dysfunction. So not kind of your typical COPD talk, but Ron's going to talk about kind of your non-typical obstruction discussion tonight in our webinar. So thanks again for joining us, and we look forward to having you. I don't know if we'll have time for questions tonight. Ron got a little slide happy on this presentation, but hopefully you all enjoy it.
Yeah. Well, good evening, everybody, and thank you for joining us. Jen and I really appreciate you doing this, and we appreciate doing it. So thanks for letting us do it. This topic, I'm sure I think I was telling Jen and RJ earlier in the day that when you read the title of this topic or this course of this evening, it says the word obstructive. And so, Jen, I purposely wanted that word because I don't want people to forget that there are a lot of individuals out there that have obstructive lung dysfunction, but do not have chronic obstructive pulmonary dysfunction. So as we start off this evening, let's all just remember, I am not talking about obstructive pulmonary dysfunction. We are going to talk a little bit about it, but I'm talking tonight about something that is not as devastating to your system as pulmonary alveolar dysfunction or disease. It's a terrible disease to be, to have your alveolar tissue so expanded that you can't get air in because you can't get your alveolar sacs to contract. This is similar, but it's dissimilar in that the obstructive activities we're going to talk about tonight have to do with positional patterns of breathing that infiltrate our ability to become unobstructive, or in the case of the other side, unrestricted. So wherever you see the word obstructive, remember, we were talking earlier this evening, if you can't internally rotate, you probably aren't going to internally rotate until you get the external rotation on the other side. Jen, we just had that conversation. You won't be able to really unobstruct if you can't do something with the other side. And the other side of your chest wall is probably restricted or restrictive in certain activities. So it's a yin-yang situation again, and we're going to go through that this evening. I like the word chronic though. When you hear the word chronic obstructive lung, chronic, the word, and you put the next word obstructive with it, you know that the obstructive issues more than likely did not happen overnight. It came on very slowly. It came on over time. So it fits that word obstructive. So does the word chronic obstructive pulmonary disease. It doesn't happen overnight. It's a slow manifestation of pulmonary, or in this case, ventilatory activity dysfunction. We're going to talk about characteristics. We'll talk about considerations. We'll start off the characteristics. I know you all have this handout, Jen, threw out at you. So if you look at it, we'll go over, I don't know, there's like 6 or 7 of these. Characteristics of chronic airflow obstruction. Now, last week, Jan, we ended up that last topic was on hyperinflation and this carbon dioxide issue. And if we recall last week, for those of you who were here, hyperinflation usually begins when you have an imbalance of activity going on between the two sets of lungs, and one becomes more dominant for carbon dioxide exchange versus the other. We all know that we have human body characteristic function of chronic airway activity that's called obstruction airway activity, more on our left side as a result of last week's discussion regarding hyperinflation. It would be a cheap shot in my mind to call this a hyperinflated discussion this evening. It is, by the way. Airflow obstruction is the result of hyperinflation, but hyperinflation is the result of airflow obstruction. So we need to talk about airflow obstruction, which is why last week was so critical when you talk about things like hypocapnia or alkalinity or pH imbalances, both in the blood as well as in the lung itself. So some of the characteristics of this paroxysmal issue, paradoxical issue, is inspiratory indrawing. Indrawing is listed a number of times in your handout. You have indrawing of the lateral rib margins. When your lateral rib margins of your chest wall start to come in closer to the center, you're becoming over-centered. Your front of your margins of your ribs are coming in an elevated way, coming forward, and so is the back of your spine. And when that happens, you start to appear to be in extended state. You really neurologically may not be in an extended state. You may be just taking a good inspiration in, and you stay there over time, chronically. And that leads into your extension tone and your extension system complementing that activity. So indrawing of your margins of your ribs, indrawing of your, I'm going to go to the third one real quick. Indrawing of number 3 of the rib cage in the anterior posterior dimension. So your anterior posterior dimension are indrawn. And you'll see a lot of people with this pectus issues. Their chest wall is sunken in, and their chest wall sinks in when the spine sinks forward. So you'll see anterior posterior dimensional changes of indrawing towards, again, the center. So it's, again, paradoxical inspiration. When you breathe in, instead of the chest uniformly opening up, the chest likes to come in the front and come in the back and come in on the sides, all while the rib cage is still going through external rotation with the ribs. So the ribs are still externally rotated, but everything's kind of sinking in. And then you know you've got an issue called obstructive lung function, which is another word for hyperinflation. We skipped one purposely. This will be some of this title, or this right here is the title of next week's webinar, Jen. We're going to talk about abdominals, but in coordination of our abdominal motion, or in coordination of our abdominal activity, I like the word motion, the abdominal movement can have a significant impact on this lung obstructive process. Decreased lower lateral rib cage motion. The lateral rib cage no longer moves up and down, it just stays out. And so with that inactivity, you start to get obstructed in terms of how you exhale air out, because the air you move in did not expand your rib cage. We had indrawing of the front to the back and indrawing of the lateral walls. And as a result of that, your rib cage literally is manifested into an elevated state. You take a breath of air in and you literally want to go to your toes. To get more air in, you got to go to your toes. An expression of air flow for somebody in a chronic obstructed or obstructive state would be an extended state. Number 5, a reduction in tidal abdominal displacement. Tidal abdominal displacement. What does that mean? That means your tidal capacity, which we're going to get into, your tidal flow, is displaced. Your abdominal wall is not in the right place. When the abdominal wall is not in the right place, you are considered obstructed. Because at that point, your abdominal contraction is only going to make the obstructive process higher. I mean, it's going to be a greater intensity. The flattened diaphragm position, complementing the abdominal displacement, reduces your overall forward displacement of the abdominal content. So this displacement of your abdominal content is part of this picture, but when your diaphragm flattens, it can't really be held into place by your abdominal content because of the abdominal displacement of the content, the organs underneath your diaphragm. Abdominal contents serve as a fulcrum for both of your central tendons of your diaphragm at rest for normal tidal volume breathing. I like this slide. When I wrote it, it made me smile because everybody wants to talk about gut and the vagal system. And I like talking about the vagal system as it relates to the gut. But the real issue is the actual size, diameter, and I'll use the word concreteness, the actual organ itself, the organs in your abdominal area serve as respiratory anatomical features. They're there to help constantly replace, reposition your abdominal wall for good opposition to the diaphragm upon inspiratory activity and good opposition, or better yet, apposition or contraction of the abdominal wall by keeping it in a better placed position. So abdominal contents and their location are as important as the location of the central tendons because it's a one-to-one relationship. In a young human adult, the tidal volume, when we breathe, our tidal volume is approximately 500 milliliters per inspiration. And we have a graph coming up to help you understand what tidal volume is. So that's just a reference. So here's that graph. If you look at that graph, and you'll see that the tidal volume is the line, are we doing okay, Jen? Between inspiration and expiration in range. So it was 500 milliliters in a young adult. On this graph, you're going to see things like functional residual capacity, FRC, and you're going to see residual volume, RV, and total lung capacity, TLC. Take note of that because we're going to come back and talk about that, including the residual volume or residual amount of airflow that is left after you blow out. We'll go over all of this activity to some extent, but I want to remind you that this image has it all in it if you want to go back and reflect. The forced vital capacity that you can see on the previous slide is the amount of air that can be forcibly exhaled from your lungs after taking the deepest breath possible as measured by a spirometer. Sometimes, this forced vital capacity is limited because of abdominal organ displacement. Or when I say abdominal displacement, I'm talking again about chronic obstructive lung function. We're getting pelted on by rain. Can you hear it, Jan? We're getting this windstorm coming through. I like this this slide, and this came off the internet, and it's an image, and we're giving them credit down on the bottom. But I love it. I love the fact that the normal lung on this particular slide is on the right side, and the obstructive lung is on the left side. You will see what you're seeing underneath individuals in patterns where they stand mainly on their right leg and try to breathe as their center of mass is over to the right side. So that's what you'll probably see in an individual who's struggling to get air out on their left side so they can get more air in on their left side, but more importantly, so they can even get air in more onto the right side. But you will see this obstructive type of pattern, mainly in humans who have rib flares on the left side, lower shoulders on the right side, heads tilted to the left, hips that are oriented over to the right. You'll see this obstructive type of an image. I also like it because the brown color, and I assume they don't have colors, but do they have colors on this? Can they see this?
They have the option to have either color or black and white handouts on the website.
So if you can go to the color option, you'll see
burgundy.
Yeah, if you can do that, you'll see the burgundy forced expiration volume in 1 second, FEV in 1, or FEV, if you just consider forced expiratory volume, will be the brown. Then you've got the entire forced vital capacity. On obstructive lung dysfunction, you'll see the forced expiratory volume become lower than normal. The FEV1 in 1 second will be lower than normal. The total lung capacity, extremely important, circulate, will be normal or higher. And that's what this discussion is all about this evening. You got way too much in that set of lungs. Your residual volume, which we're going to talk about in a few minutes, is also going to be higher. So the residual volume in our left lung usually is a little higher than the residual volume in our right lung if you don't have good operational activity between the two lungs from side to side with movement and breathing. So a great overview, great image of what normal versus obstructive looks like. Obstructive, another word for that would be hypocapnia. Another word for that would be hyperactivity. I'll pull this slide up. I know I'm a little early with this, Jim, but I'm going to pull it up. Anything last week in the red area would be a reflection of obstructive lung function. So if I crossed out the word respiratory alkalosis, those two words, and put down obstructive lung function, everything underneath of this would be the same. So the 2 weeks are meant to tie in together because I'm building a picture here. What are we really trying to do to balance out our vital capacity, our residual volume, our total lung capacity? What are we really trying to do? Well, obviously we're trying to normalize it. And it's a biased system, so we have to be mindful of that our normalization of a biased system cannot happen if we first don't deal with the obstructive forces that are eliminating the ability to increase your forced vital capacity and decrease your residual volume of the lung tissue that's hyperventilatory and hyperinflated, which is often seen on the left side. Although this test may help distinguish obstructive lung disease, such as asthma and COPD, from restrictive lung diseases, such as pulmonary fibrosis or sarcoidosis, it is a very valuable tool to assist in demonstrating improvement in lung obstruction immediately after treating somebody with a procedure you might be using to help them get air out for chronic airflow obstruction. And I think I already talked about it. Did I talk about the spirometer? I said it earlier.
Just briefly.
Briefly. So we're getting into it. So what I'm referring to here is expiratory spirometer, expiratory spirometric work. And this young lady's got a spirometer in her mouth. It's not an inhale spirometer, it's an exhale spirometer. And we use this Spiropet. I've used it for years. I can't tell you, I think I'm in my 3rd decade of using this thing. They haven't changed much over the years. You don't want to drop them, but if you keep them clean and you don't drop them, they'll last a very long time. It's a windmill type of spirometer. They are pretty active. They complement much of the research out there regarding milliliters, and I really like them. So they're simple. I don't know, Jen, they're like, what, $200 I think today, but that's what I use. And again, there are a lot of them out there on the market. You can pick any one you want, but I like today's talk reflect expiratory spirometer work. I also like the position she's in, Jen, if we can go back to it. She's in a position where her left elbow is next to her left rib cage with her right hand above her head. So I'm assisting in reducing the obstructive function that she has on her left side by keeping her elbow in that position and her spirometer in her mouth, as you see in that image. Knees are bent, Jan. Head's not on a big pillow. Just please take note of those little details. When functioning with a limited zone of apposition on one or both sides, the readings on the exhalation spirometer can be greater than normative values because a persistent state of hyperinflation leaves a high level of air which has not been exhaled in the lungs yet at rest. I'll hang here a little bit. So when you put the spirometer in your mouth and you blow out, it looks like you're blowing out enough air for 3-4 people. That's because that first blowout, there's a lot of air you're blowing out from both lungs. So not only do you have airflow coming out of the left lung, you also have it coming out of the right lung. Normal airflow out of the right lung with additional abnormal airflow out of the left lung makes those values very high. Now we could talk about this all day, but again, this little spirometer serves as a good test procedure to determine whether or not the activity you're doing with your patient is really effective or not. Now that's the initial blowout, Jen. After restoring a zone, in other words, after getting those ribs to more or less move first, just get them moving. Hopefully the rib cage on the left side will internally rotate before the rib cage on the right side will externally rotate. But movement's got to happen first from both of them. And movement happens when you exhale out with lung obstruction and chest obstruction. You got to move air out before air is going to move ribs out away from the center, or in front, forward, and then in back, as we talked earlier this evening. So for your body weight to move closer to the ground, you have to get air out. Don't worry about deep breaths in at this point. Think about getting air out. Chronic obstructive lung patients need air to come out. Write that, because that's exactly what we're trying to do. And if I have to work a little bit and I'm helping those ribs move that air out with my hands on their rib cage, I'll do so. If I have to put them in more of a rounded position, like a hammock position, pillows under their neck, pillows under their upper body with a little pillow underneath their tailbone, I'll do everything. I may even put them in a chair. It's called the Hoover sign position. People with a chronic obstructive pulmonary disease get into Hoover positions to breathe. We get these people in Hoover-like positions to exhale, to get air out, because the rib cage is beginning to function in a state of more normal internal rotation when you do. This is called unobstructed positioning. So, you know, when you get into that state where your ribs are coming down closer to your pelvic floor or your anterior pelvis, you're going into an unobstructed state. And that has less volume associated with it of available air for exhalation. Now, the next breath in, when you're in that in-range unobstructed state, will be magical, because the next breath you take in, Jan, is exploding that chest wall. And with that explosion of chest wall, now you're starting to get internal rotated ribs, which is what your desirable state is all about, to distract the spine, to allow things to open you up and give you unobstructive, non-restricted airflow. So anyway, the most common contributions of chronic airflow obstruction are, number one, lateral rib cage paradox caused by diaphragmatic contraction because of the abdominal orientation of the fibers in the overinflated chest.
Not abdominal.
Abnormal, I'm sorry. Lateral rib cage paradox caused by diaphragmatic contraction because of abnormal orientation of the fibers in the overinflated chest. I think I would have caught it, but I'm glad you did. Next week's talk is on abdominals. But it's abnormal orientation of those abdominals that creates that overinflated chest. Thanks for keeping me honest. Number two, abdominal, it's all about abdominals here. Abdominal muscle relaxation at the onset of inspiration, underline it. Abdominal muscle relaxation, latent abdominal contraction at the onset of taking a breath in. So instead of people taking a breath in with good opposition to their diaphragm, they take breaths in, Jen, and the minute they take it in, the second they start, they go right into their obstructive pattern of chest and lung function. They start to extend. They don't really extend. It's the chest's obstructive activity that's making the latent activity of the abdominal wall exist. So secondary to overactive psoas and paravertebral contractions at the early onset of inspiration, you'll see a period of obstructive lung function, which is the title of this discussion. Over time, it becomes chronic, and the abdominal muscles become now weaker in the earliest onset of inhalation. So that's really what it's all about. Keeping those abdominals on at the earliest stage of inhalation is what you do to reduce chronic obstructive lung dysfunction. Even your COPD patients would love this discussion. They want to get into that Hoover-like state, so the abdominal muscles at the earliest moment you start to breathe in will start to exchange more for them, because of their alveolar tissue is very limited in what it can exchange. It cannot exchange as well when they go into a hyperinflated extended state. So I love this slide. And again, that's why next week we're going to talk about abdominals more. This week, we have to understand functional residual capacities. With obstructive dysfunction, you become hyperinflated, and your functional residual capacity, what's left over, is increased. And overuse of your accessory inspiratory muscle is also going up. In attempting to overcome external resistance load, lateral chest wall obstruction at end expiratory phase. So not only do you have a problem at the early inhalation phase of breathing, you have a problem at the end expiratory phase of breathing, where the resistance of your chest wall is now at its highest. In other words, you have such high resistance at in-range expiratory phases that your chest wall is now like a board, a block. It won't move anymore. It's locked up. So functional residual capacity, FRC, is the resting volume at which the elastic recoil pressure of the lung inward equals the elastic recoil pressure of the chest wall outward, and the alveolar and mouth pressure are both zero, and there is no airflow. So it's stagnant, and everything's locked up. Balance is between the chest wall that's moving outward and the lung that's moving inward, and that's obstructive. You're done. You can't move anymore. You're at the end range of exhalation. So again, here's that same slide I showed you earlier, and you can see that with this slide, it can happen on both sides very easily. You can see elevated ribs on both sides in individuals who are locked up. When that stagnation continues to go on in life, it usually starts on the left side, as you see in that diagram. Now, this is different than restricted. What you see on the other side is restrictive activity. And the problem with this slide, they have the left lung showing the restrictive activity. Well, normally you'll see that restrictive activity on the right lung, like you did in, sorry, Jen, I'm doing this to you, in this slide. So in this slide on your handout, they have this on their handout, this slide, cross out the word normal on the right side and write the word restrictive. Then on the next slide, you'll see what restrictive means. Restrictive means that your forced expiratory volume of 1 second is now normal or greater. And your forced vital capacity now is lower. And your FEV1 and your FVC is higher. So all these arrows are going the opposite direction. Your total lung capacity went down, and your residual volume is way down. So obviously, write down this word next to those two slides. You're a twisted person. You're really torqued up. You're really struggling to balance out the restrictive activity on the right side and the obstructive activity on the left side for normal balanced breathing. And we see that a lot. And in these days where people are having a tough time with COVID, the best thing we can do with these COVID patients is balance out that airflow and get the left side more, I know this is hard to understand, maybe not, more obstructive, and get the other side more restrictive. That would be your left side, as you see in this slide here. What's that?
Can you repeat that? Because I think you said both for left side.
In the COVID times we're in, with lung patients that come in, they all have similar lungs. The right side is usually what? Restrictive. The left side is usually what? Obstructive. Underneath. They can have obstructive lungs on both sides, Jan, or restrictive lungs on both sides. But the obstructiveness and the restrictiveness, it will be higher obstructiveness on the left side and higher restrictiveness on the right side, okay? Our goal with all those patients would be to create a little more restrictiveness on the left side and a little more obstructiveness on the right side. So all I'm saying is to balance out the inequality of the airflow. We really won't do that intentionally. We'll do that by taking the left side obstructiveness and reduce it. We'll get those ribs in a position where there's more opposition, which will de-restrict the right side and de-obstruct the left side. Was that helpful? Whoever wanted that?
I think you said both of them as left side.
And it can be, but not with this discussion. I said both could be the left side.
I think you said to make the left side more obstructive and the right side more, and the left side more restrictive. I think said both of them that.
Oh, I didn't want that. If I did, I apologize. But I hope I
Maybe I misheard it.
But I hope I cleared it up right there, right? Okay. Now, regardless of whether or not the lung is obstructive or restrictive, what is important is that when you look at people who cannot get air out, they have an increased oxygen level in the blood due to decreased carbon dioxide in the blood and the lungs. We went over that last week, that whole carbon dioxide discussion. Some of the other characteristics of obstructive lung function is loss of costal diaphragmatic fiber function, which is your zone of apposition function, with upward elevation of the anterior ribs. So you'll see this came out of this Detroit article, Journal of Applied Physiology, 2016. Now,
I included that on the handouts as well, link to it because it's free online.
Yeah. A couple comments. Andre Detroyer has been around for years. This is one of my best mentors. I've read a lot of, in fact, we have a lot of articles written by Detroyer in our library. But things like zone of apposition and Hoover's sign in this article, it's an easy print off, right? I mean, it's easy. So print it off, right? And take a look at, this is a really symmetrical picture. Costal diaphragmatic fibers, zone of apposition fibers. And the reason I'm throwing it in the slide right now is that is what we would try to do with any program, is to balance out the two central tendons of both your diaphragms. So your zone of apposition looks like that. There is nobody that I would ever have been able to work with or will work with that will have a balanced zone of apposition that looks like that diagram. But my goal is to reduce chronic obstructive lung dysfunction or lung function by making sure the zone of apposition that you see on that individual's left side is really taken into account. And that's what we're going to do the rest of the evening. So forward head postural movement is also a characteristic of obstructive lung function. Forward head postural movement associated with chronic obstructive airflow contributes to pharyngeal, velopharyngeal, and oropharyngeal airway and shape. And again, I'm going to take a moment and pause and really understand, really appreciate airway shape. Underline the word airway shape, which is what we're going to talk about right now. Airway shape, airway form is therefore related directly to obstructive lung activity. So keep that in mind as we get into this dysfunctional state of airway shape and form, you can't really change airway shape and airway ellipse form if you don't first go after lung that is dysfunctionally displaced, secondary to chronic obstruction or chronic obstructive lung function. When the abdominal contents move up into the thorax and you lose your zone of apposition, everything moves up and forward in your thorax, your lung tidal volume decreases. You're not exchanging much. Therefore, the tension with the walls of the upper airway decreases. The tension goes down. Therefore, that increases your upper airway susceptibility to the biggest word, the biggest adjective, collapse, or biggest adverb, collapsing. Your lungs now collapse on the upper airway along with the airways that go up through the nose and into the mouth. Individuals with chronic obstructive lung dysfunction have upper airway ellipses oriented anterior-posterior, making the lateral pharyngeal walls more susceptible to collapse. And what I did is I drew this out on this whiteboard. These webinars, you only have so much time and so much to cover, but I'm covering this briefly to remind you the slide that you're looking at. If you were to look at an ellipse, and I really think I'm going to read this to you, Jen. Jen, an ellipse is a plane, and you guys can Google this, but I think let's just take a minute or two to talk about it, is a plane curve surrounded two focal points on the curve, okay, such that for all points on the curve, the sum of the two distances to the focal points is a constant. It's constant. So if I put a point here and a point here, a point here, a point here, it's going to be a constant for it to be a true ellipse. Now what you're doing, or what I did, is I'm looking at the trachea, the airway, from here, somewhere above the lung, from the top down, right side, left side. There's the ellipse. That's a normal kind of looking airway. So your airway ellipse is more long from right to left than it is front to back. But we just read this slide that says individuals with chronic obstructive lung dysfunction have upper airway ellipses that are oriented anterior posterior. Remember earlier, Jen, I said in the beginning of this talk, everything wants to come what? Forward and in. So that's what it would look like if you were looking at it posterior and anterior, but you're looking at it from the front. But if I flipped it up where the A went up and the P went down, your ellipse now is going anterior posterior, and it's easier for things to what? Collapse. Your susceptibility to collapse is higher here than it is here. Airways become narrower with obstructive lung dysfunction. Next slide, I think, will talk to you about the transverse plane. Whereas individuals without obstructive lung dysfunction, the long axis will look like that in a transverse plane. So the right and the left will look more like that. And if I just flipped it like this, like I did up here, it would be less susceptible to collapse. It's more acceptable for rotation in the transverse plane. Airways need their ellipses like this versus this. This is a sign of obstruction and restriction. The following PRI techniques that I selected tonight for this webinar should reduce this obstructive airway problem and lung dysfunction because of the foot, floor, and shoulder hand positional interaction during reaching and respiration. You minimize collapse through, therefore, reaching and breathing, getting air out, keeping in mind that you have to have a floor that's on top of a foot that's on top of a floor, and a hand and a shoulder that's working with that foot on that floor for interaction with reaching and exhalation. So we picked 3 tonight, and what I want to do is take all 3, briefly talk about them. We'll read the title, Jen will read the title. This first one, I think we'll just go through it slowly and talk about some of the concepts associated with it, keeping in mind the underlying goal for these obstructive lung function dysfunctional patients is twofold. Number one, we got to get the floor and the foot to stay grounded as arms, shoulders, and hands, Jen, reach. That is a obstructive lung dysfunction killer program. That helps susceptibility to collapse go way down. That improves all the FRC and some of the subtitle volumes that we're going to see here in a minute with this, improves all of that. It's a great activity for your COPD patients also. So just because we're talking about obstructive lung dysfunction, put in the words obstructive pulmonary dysfunction, and it'll work just as well for them as it will for the latter, or in this case, the topic of this evening is chest wall and lung obstruction, not alveolar dysfunction. You'll need about 5 to 7 feet of medium resistance therapeutic tubing. Can you get that on our website? I don't know.
Yes. Well, I mean, there's a link to it. We don't
Okay.
sell it directly, but there's a link.
So if you go to our website, you can purchase there, but Stretchwell is what I've been using all these years. And I would go with green. I wouldn't go above green. If you go above green, you're becoming a strength-minded person. If you stay below green, you're neuro. However, you can perform this activity without bands resistance by placing your hands on the edge of a chair that slides easily forward on the floor as you reach forward. You can also find a book that's approximately 1 to 3 inches in height and at least 12 inches long, so they can get both feet in front of it, and at least 7 to 10 inches deep. And I would lay closer to the 7-inch mark. So you want about 7 inches between the back of your heels to the wall that you're doing this activity on. That's critical for us to get exhalation activity at its highest. When performing this activity and standing, you'll be able to use the floor as an anchor, remind yourself of that, and a wall as a support. And our goal is to distract. So when the wall becomes a support and the floor becomes an anchor, you'll distract. When the floor is a support system and the wall is an anchor system, you're compressing. So keep that in mind. Your lower and upper posterior chest walls need to distract, not compress. This position on the floor and the wall will allow you to primarily sense. Can't do it, I can't leave it. Sense and focus on mid to low back lengthening as the accompanying posterior and lateral chest walls expand. That's the antithesis of the activity that's going on with somebody in a chronic obstructive lung dysfunctional pattern. And again, that's why this is one of my favorite techniques. Whether you understand PRI, not PRI technology or not, this is one of the best positions you can put somebody in. It's like a modified Jan Hoover sign activity on steroids, okay? It's really important to keep that in mind. Therefore, the floor you are standing on and the wall your lower back and hips are resting on, and the bands that are looped around the hands, or the friction from the legs of the chair, the hands are resting and pushing forward on, are all providing forces needed for your left and right diaphragm leaflets inside your 2 respective chest chambers to open and expand and stretch both the inside and the outside of those chest walls. Before I read anything else, Jan, that slide says, even if you don't know what you're doing from this point on, just getting in that particular position is going to start changing tidal volumes, FRCs, all the things that were on that chart that related to restrictive and obstructive activities are going to start to go the opposite direction by just getting into that position. This expansion under the above guided resistance allows your chest chamber to ideally open better when closure of the other chest chamber occurs. Here's, I think, a misnomer, Jen. If you think you got to go after things like this on both sides, please think again. Your body doesn't want you to go after things that are obstructed or resisted by going at that problem from both angles, both sides. Pick a side. And we're obviously going to pick one, as you're going to find out. Because if you don't pick a side, your ability to really get to your ideal goal is going to be really reduced. It's going to be very difficult to get there if you didn't start off with a chamber doing something different than the other chamber. So keep in mind, that's an important slide. So keep that in mind. You're going to go after one side so you can ideally do something better on both sides. The PRI chest wall technique minimizes pulmonary or lung static function, and it maximizes your elastic tissue recoil of the chest walls. Therefore, it equalizes the pressure when all four extremities are alternating or involved with lifting and assisting with optimizing your immune system and responses, as we talked about in the former weeks. Step 5 is where the magic really happens in my mind, Jan. The magic is when your inhalation effort through your nose after performing step 4 continues to open up the entire chest wall cavities on both sides, along with all the underlying alveolar tissue in your lungs. It's kind of like the spirometer. You take the spirometer, you put it in your mouth, Jan, you blow out that air, and the first value is, a lot of air came out. The second breath in and out, a little less air came out. Third breath in and out, all of a sudden maybe less air came in, but maybe now the values went what? Up. Because if the values come up on that third and fourth breath, your lung and everything in your alveolar tissue did what? Expanded. And this is an activity that can do marvelous things, magical things, without a spirometer. But they're very, very similar. In fact, when I see the picture of that lady with that green band in her hand, I want to call the spirometer technique, because that's really what it is. It's a spirometer technique for this last sentence, to open up the entire chest wall cavities on both sides with a little bias activity. I don't think I'm going to read anything. Did you want to add anything on that one, Jen, as you look at it? So 4 to 5 breaths in through the nose, out through your mouth. Do it in a very slow, methodical way. Keep in mind that every breath in after the second or third breath out is more critical than the breath out. The first few breaths should be concentrated on breaths out. The second, third, fourth breath should be concentrated on breaths that come what? In. Because the green band is going to make sure the opposition is allowing you to breathe in now with correct activity that's going to de-restrict the right side and de-obstruct the left side. I think I said that right. Unobstruct the left side. So keep that in mind. And it goes on to tell you a little bit about moving your left hand forward. I believe it says that, right? You should feel a stretch in both hips as you move your upper, as you move through, air moves through your upper back. If it doesn't say, and I think it's bilateral. You can also begin to move your left hand slightly forward, Jen, than the right hand for those individuals who are really very obstructed on their left side. So you move that left arm forward to get a little more air out than you did with the other arm. As you get that air out, you're going to get more air in, both in the right side as well as the posterior tissue and the posterior chest wall on the left.
Wouldn't you move the right arm forward to get the air out and then the left arm forward to help
You
get the
could.
air in?
Yes.
Like last week's
That's what we did last week. But for this technique for obstructive activity on the left side, you'd move that left arm what? Forward, hold it, and breathe in to get that air in. But last week's discussion's perfect.
quick question that came
Yeah.
in before we move to the next technique. Betsy asked, why did he choose the one with the ischiofemoral ligament stretch rather than just the resisted reach? We have
Okay.
one that's just a resisted
Yeah.
hand reach.
Because Betsy, the number one reason is because I want to do everything I can to floor this client up, because the psoas muscles are very strong. The paravertebrals are very strong. Obstructive lung dysfunction patients have very, very strong hip flexors and back extensors. You need everything you can, including the ischial seats and the calcaneuses, to keep your feet on the floor. That's the answer. Anybody who's really obstructed and has obstructive lung function, dysfunctional problems, you've got to keep them on that floor. They've got to be pulling themselves to the floor. And by putting a ball between those knees and by keeping your back in the position it is, Hoover position, you're going to do a much better job at the end range of this, at the end of this technique, not range, at the end of this technique, when you take a breath of what? Air what? In. You've got to make sure, it's like having 3 people, Betsy, one on each ischial seat, holding those ischial seats down, as the other one, as a third person, is on the rib cage, moving those ribs down, and with all that force, when that diaphragm contracts, things are going to happen. It's called magic. Obstructive lung dysfunction dissipates. That's important to understand. So that was a great question.
Well, and you're going to get more posterior outlet or posterior capsule expansion, which in turn is going to get more posterior chest wall or posterior mediastinum expansion too.
Love it. Love it. Very good. Okay, any other questions on this one? Okay. This is my second favorite for obstructive lung dysfunction. I'm not sure how many people even do this, but you don't need a band. I'm not sure you even need the green ball between the leg, but I love the heels, the quads are on, the knees are flexed, the back is rounded. It's almost like he's sitting in a chair and reaching all the way forward without falling. I won't read it, but I'm going to give you some of my thoughts about some of the steps. When you bring your arms out in front of you as you round out your back, performing a pelvic tilt, so your low back, mid back is down, kind of flat on the wall. If you can't, that's fine. Just keep the hips on the wall. You are doing this. By placing your arms out in front of you, you are separating the shoulder from the chest wall. Obstructive lung dysfunction patients have shoulders that are married to the chest wall. So this is a great subscapular stretch, a subscapular release. You're moving the shoulder blade forward and a chest wall back, which assists in the normalization of FVC and FRC. I remember in my earlier years of life, Betsy, when I studied pulmonary and cardiopulmonary work, I never could understand why we would work on all these, functional residual capacity activities and, vital capacity, functional vital capacity, functional residual capacity, and nobody was ever talking about the shoulder. The shoulder is residual, and vital capacity. Just remember I said that. The shoulder is vital, the shoulder is residual capacity. Your values are going to be reflected by your shoulder for function. Jen, you know how I feel about a shoulder wheel. We got in this discussion a long time ago, but just recently, they kind of disappeared. But all our cardiopulmonary patients in the VA Medical Center I worked with, before we did any cardiopulmonary testing, they had to put their shoulders on that shoulder wheel, and they had to make sure they understood how to move that shoulder wheel with knees that were flexed for functional, residual, and vital capacity maximization. So I think that's important for you guys to understand. Step 3 is major. Shoulders got to move forward. It's not always about a chest. A chest locks up when a shoulder marries it. Step 4, keeping your lower back against the wall as much as you possibly can. Again, Reach forward and place your hands on a movable surface, rolling chair or stool. By keeping your low back or posterior hips against that wall as much as you can, and placing your outstretched hands on a movable surface. Done. Dealed, sealed, deal. Because the minute you try to keep your sense of that low back on that wall, and the roller in front of you is rolling around, you just decreased the obstructive and restrictive issues in that chest wall because of those two issues. One, non-movable surface behind you. Two, movable surface in front of you means non-obstructive activity inside of you. The floor becomes a force that reduces the positional obstructive lung dysfunction upon inhalation. It is an instant abdominal grabber. Your abdominal muscles are instantly on in that step. You don't have to worry about it. You don't have to think about it. You don't even have to sense it. They are on. Now, we're going to talk about this a little more next week, but this is a great technique to take that individual who doesn't know how to use your abs on early phases of inhalation, those early steps of inhalation. If you want early responsive abs, put a movable surface in front of you without the wall leaving your ischial part of your body. I love it. I love this one, reverse squatting. I don't care how poor you are about the first step Bobby is showing you. Just get there somehow. And even if you can't get all the way down, let's say you're the third picture in, and that's the best you can do. I'll take it. Just start in that position. I'm not trying to go there. I want to start in those first few positions. This technique requires unobstructed movement, underline it, unobstructed movement of the mid-back. Just to start there, you're starting with unobstructed demands. You're saying to your brain, I don't want to obstruct. I don't want to obstruct my lungs. I want to let them go. And you do that by just getting into a start position where your mid-back and your lungs are on a set of knees that are moving, Jen, forward. During the time, the back is reversed, which is why we call it reverse squatting. Your back has got to reverse. Your back has got to go in reverse. Your back has got to go backwards. Humans like to bring their backs. An hour ago, we said backs like to go which way? The anterior posterior ellipse likes to get close. It likes to come together. And when you have that, you have what we call forward squatting. I would say surmise a large percent of your patients out there do not squat correctly. They are forward squatters. They're not reverse squatters. They don't know how to get in reverse squat. They don't know how to squat with their backs, Jen, going what? And their knees going what? As they go down to that floor. So during the time the back is reversing, the hands have got to go forward. Hands go forward, backs go back, unobstructed. It's like a little CPR going on inside of you, jackhammers, pushing you out, not pushing you in. This requires significant postural control. Significant postural control. Our institute significantly believes control is necessary with a back going back, especially in the thoracic lumbar region, the lumbar area, Betsy, where we were talking about earlier. This is an ischial issue. The ischial seat's being pulled by a knee that's going forward, by hamstrings that attach way down there to a tibia. So it increases your FVC at step 2, at in range of exhalation. And from the shoulder blades, look at her shoulder blades. They're leaving the ribs to decrease FRC at step 3. This is kind of cool. I'll bet when they get done, their pulmonary testing is going to look completely different than before they did that test. So before they did this technique. So if you want to maximize the increase in FVC and maximize the decrease in FRC, I would think about reverse squatting. It's a pulmonary, and I would dare say cardiac technique to get your lungs and your heart in a position where they can instantly feel physiological change in pHs of the blood and the airflow because of that position. This is a great way to get the FRC to decrease at the in range of inhalation. So the bottom picture is a great position of in range of inhalation, and the top picture is a great picture of in range at exhalation. And this webinar gives me, the speaker, the director of the Institute, an opportunity to go over 2 steps, Jen, I would not have had in other courses. So I want to thank you for those of you in this room. I want to thank you for listening to this. Extremely important to understand the physiology behind the PRI techniques as related to these kind of webinar material. I want to thank you so much for letting me go over that. Jen will tell you, I thoroughly enjoy it. RJ was telling me numbers weren't going to be as high tonight. And I said, you know what? I'm having so much fun. I'm enjoying this. It's good for my soul to talk about things that I don't get a chance to talk about. So thank you for permitting me to do that. And I also want to tell you that in the end here, this compendium, you'll go back and look, and you'll see how week 8, 9, and 10 relate to week 1, and how week 1 and 2 supported it all. So I appreciate you for those people coming back and sticking with it. I really, really, truly appreciate it. So thank you. Jen?
We could take a couple quick questions. We have severe weather heading right into our area, but if someone has a couple quick questions, I'd gladly, we appreciate you guys joining us live. So if you do have a question, you can chat it over to me real quick, and we'll try to answer it before we head home and try to beat the severe weather.
Okay. Are there any?
Don't have anything yet, but we'll give it a second here.
I wouldn't mind. Skip, are you laying in your chair? See it. Skip, how'd the evening go? How'd this go for you?
Hey, Ron, it was great. I mean, this was, I think, such a great overview of obstruction versus the diagnosis of obstructive disease.
Right.
I thought it was terrific. And I also think how you wrapped it up with tying in FEV and then the techniques, it was just great.
Yeah.
So I appreciate it very much. And it
more.
also helps so much with my understanding of postural respiration.
Yeah. Well, that's why I asked you, because Skip, this is your blood. This is your physiology. This is how I met you. This is what you were talking about. So to get you in a room like this tonight, I'm honored. Thank you for being here. I think you, of all people, would have said that. You would have said, look at the relationship of capacity, residual capacity, with a technique like this. And keep in mind that that's what this is all about, balancing out capacities. And obstruction and restriction take away that balance. And it's bigger than us putting emphasis on, do you have a glute med? Do you have a hamstring? Do you have an abdominal wall? So I really appreciate you being here.
Thank you, Ron, for doing.
Sorry, I muted you, Skip, here. We have 2 quick questions here we'll answer. Can you explain more about the 7 inches from the wall?
I would love to. 7 inches is not going to be whoever asked that, it's not going to be in any other material except PRI. And the reason for 7 inches is because it's an area over time, 25, 30 years of practice. I can tell you it's one of the best ranges that most of your patients are going to benefit from. If you go less than 7 inches, it's very, very difficult for you to stay in control of the floor. If you go less than 7 inches, your heels are going to be coming up. If you go more than 10 inches or more than 12 inches, you're leaning, you're laying back on you're not getting the ground. So the 7 inches puts your feet squarely on the ground and makes your back aware of the wall without losing sense of the wall and without losing sense of push through your heels. Therefore, wall, heels, ischial seat. So it's just based on my interpretation over the years, Jan, whoever asked that, my interpretation of what my patients were telling me. And at that time, I have to tell you a truthful story. The Lincoln telephone book had this telephone that was exactly 7 inches. And I always was going, and we taped them up. Jan, you've seen them. We taped up. How many did we tape up? We would go on the streets and collect all the old ones when they threw them out, because, you know, now everything's paperless. We can't even get an old telephone book. So I think if you go over there and take some of that tape off those telephone books, you're going to look at telephone books that were put together in 1998. They're all taped up because they were perfectly made. There was 2 years there, Bobby was just collecting them. And then we would give them out to patients that came into our office. That's the true story. So thanks for the question.
All right, one last question here before we finish. Patty said, my phrenic nerve was damaged and forced my diaphragm against my right lung. Will these exercises help?
Absolutely, because it takes the constraint, Patty, off the knee, off the residual strength left in your diaphragm. Now your diaphragm has innervation from ipsilateral and contralateral phrenic nerves. So if you damage that connection on that central tendon, you're going to get carryover from the other one. So keep that in mind. But taking tension off the diaphragm by giving the chest wall more elasticity from these 3 activities will mind blow you. Try it. You're going to feel, you'll take a breath of air in and you're going to feel like the effort to do that is so much less than it would have been before you did them, because the chest wall's elasticity, intercostal flexibility improved. So your impedance, Jen, went down. And if your impedance went down, the balance of restriction to wherever your obstruction is in your body is more leveled out, because now the diaphragm that you have left is going to be doing more universal work than segmental work. And that's what it's all about, especially if you have one central tendon more damaged or more compressed than the other one. So the answer is, I'm going to tell you, absolutely.
Okay, sounds great.
Thank you very much, everybody. You all have a good evening, okay?
Have a great night.
See you next week. Thank you.